Great. And with that, I'm excited to welcome and introduce our presenters for this afternoon, Glenn Davis, Rebecca Einhorn, and Hunter Sinclair, all from Teladoc Health. Teladoc Health joined MHPA as a bronze partner earlier this year and has been a great addition to our membership. Glenn, Rebecca, and Hunter will be presenting today's webinar titled Engaging Medicaid Members with Multiple Chronic Conditions for Effective Care. With that, I'll turn things over to Hunter.
All right. Well, thank you, Eric. We have really loved the partnership, both on this webinar and across this past year as we've joined MHPA, and thrilled to see a lot of familiar faces in the audience today. I'll be sort of our MC today. My name's Hunter Sinclair, and I'm Teladoc's Vice President for Solution Strategy with Government Programs. So I have the privilege to work with our Medicare, our Medicaid, and our Marketplace plan partners, and even more importantly, think through unique ways that we can serve Medicaid, Medicare, and Marketplace members, whether that's different means of engagement, different ways to target different HEDIS measures. In my background, I have spent a lot of time in strategy consulting and then working as well in a lot of large MCOs like Humana and United. And then Rebecca, I'll hand it over to you to do sort of a quick introduction.
Wonderful. Thanks, Hunter. Hi, I'm Rebecca Einhorn. I am the Senior Director for Strategic Segment Engagement. And in this role, I help to build focused journeys to engage our members, including Medicare and Medicaid populations. Looking forward to a great discussion today.
And I'm Dr. Glenn Davis, one of the executives from our clinical programs team. I work with our chronic care management solution, our clients who are using our chronic care management solutions to help them understand the program a bit better and make sure we're delivering the outcomes that we expect to see. Prior to my time in this role, I've been a primary care pediatrician and also served as a physician executive in a large multi-specialty group. And I've also worked with other innovative healthcare companies to help develop novel solutions to help manage chronic conditions. It's nice to meet all of you.
All right. Well, perfect. Thanks, Dr. Davis. So in terms of how we wanted to spend our time together, I wanted to spend a little bit of time just introducing Teladoc and more importantly, talking about some of our Medicaid partnerships, just so you have a sense of where we're coming from, how we're coming to the conversation. Wanted to also talk about some of our latest chronic care research that we've done over the past 2 months, really understanding what it's like to be living with multiple chronic conditions, particularly for a Medicaid member who may not have some of the resources that other members might not have. And then I'll hand it over to Rebecca to really drill into what sort of trends we're seeing in member engagement in general, but particularly with our Medicaid partners, and then end where, I think why we do what we do, looking at the clinical impact. So turn it over to Dr. Davis to really talk through some of the trends and more importantly, the results that we're seeing. If you're not familiar with Teladoc, we've actually been what we say is the world's leader in telehealth for over 20 years now. I think a lot of people became aware of telehealth, in the last 2 or 3 years. It certainly has caught on, but this has been something that we've been progressively building and really honing our expertise and really building an incredibly large, diversified business focused on the simple concept of providing convenient, high quality, accessible care, virtual care. So over 80 million Americans have access to our telehealth services. A lot of people, when they think of telehealth, they think of what we call telehealth urgent care. Talk to a board certified physician in 15 minutes or less. I looked at some of our wait times recently, and there's some states where it's under 4 minutes in order to get to a physician. And that's great, but that's increasingly becoming sort of a table stakes as you think about virtual care. And that's why it's so important of where we're investing, where we're growing, is in mental health, being able to do telepsychiatry, teletherapy, digital therapeutics. We've got a range of solutions to really help solve the mental health epidemic and crisis. There just aren't enough providers to go around, and we see telehealth really bridging that gap and providing care to people that really need it. And then chronic care, where we're going to spend the bulk of our time today, thinking through, the model's broken. People with chronic care, especially in America, aren't getting the care that they need. They're not getting the results that they need. Increasingly, we're dealing with members living with not 1, not 2, but 3, 4, 5 chronic conditions. It's incredibly challenging from affordability, from a diet, from just living your life. And so we have over 800,000 members actively using our programs, where we're combining technology, virtual care, and that human element to really provide people with tangible, digestible information about how to manage their chronic conditions and getting results at scale. And then we have a number of different specialty and primary care resources going beyond sort of these more transactional ways of telehealth to really becoming a potential bricks and mortar replacement. So have started that in 2020, have increasingly scaled, not offering to Medicaid partners just yet, but having a number of conversations with MCOs, including I think a couple of you that are on the line today. In terms of our Medicaid footprint, so Teladoc's been around for 20 years, over 80 million lives, and increasingly a lot of those lives are Medicaid. So about 14 million Medicaid members have access to our services in about 25 states. So hopefully by the end of the next year, it's going to be closer to around 28, 30. Not knock on wood, but seeing just great partnership across. We've got about 50 different state plans that we're partnered with. And representing about 50% of the Medicaid market. So still significant opportunity to continue to bring our virtual care services to new states, especially as a lot of these Medicaid states go to RFP and they're rethinking. They haven't talked about services since before the pandemic, and telehealth is a critically important capability. So we're seeing a lot of interest from MCOs as they're thinking about how do I innovate, how do I continue to provide timely access to my members. So enough about Teladoc. I really wanted to give you some sort of insight, some takeaways from this time together. So we've been, with 800,000 chronic care members, we've got over 2 billion data points, but we also wanted to get an external opinion. And so we constantly commission surveys like this. So we brought in about 7,000 US adults across May and June, sort of between that 26 to 70 years of age. Both members with chronic conditions, without, those with multiple chronic conditions, including hundreds of Medicaid members. We wanted to make sure we had a lot of sampling across different lines of business. Some of you in this audience, especially those of you that are clinical, I don't think this is going to be surprising, but really wanted to give you some of the headlines, and then we'll unpack these a little bit more. Living with a chronic condition makes it more challenging to manage your care, full stop. It is hard to navigate the U.S. healthcare system. It's really hard if you've got a chronic condition. And then a lot of our members said it was twice as likely to obtain high quality care if you were living with a chronic condition. And then 46% were saying that the chronic condition made it more difficult to manage their healthcare. I mentioned mental health earlier. We find that mental health challenges, struggles are an amplifier for chronic care. That not only is it causal, but it's a correlational effect of that 45% of those living with a chronic condition also had mental health concerns, and 48% said their mental health issues were a result of or had negatively impacted their chronic condition. For our members struggling and living with diabetes, we often find that it leads to depression, and that depression might make it harder for them to exercise, make them harder for them to eat right. And so it's sort of the cyclical factor, and that's why we think addressing both the physical and mental health care is so incredibly important in order to get the results that we've been able to achieve. And then finally, we don't live in isolation. We are products of our community. And so a lot of the social drivers of health disproportionately impact people with chronic conditions. Some of the biggest differences in terms of feedback for those with and without chronic condition was around medication affordability, food insecurity, stress level. And we'll talk a little bit about more some of the unique factors we saw with our Medicaid members included in the survey. Sort of unpacking that social drivers of health a little bit more. This slide is looking at for members with 0 chronic conditions, those with 1, those with 2 chronic conditions, how they answered differently. And so medication affordability became a drastically higher issue for those with 2+ chronic conditions. Food insecurity, drastically higher for those with multiple chronic conditions. And then stress levels, high across the board, but particularly high for those with multiple chronic conditions, really illustrating that fact that living with multiple chronic conditions can make it really hard to sort of manage your whole life. And then some of the feedback we specifically heard as we looked into the Medicaid respondents in the survey. Again, no surprise for this audience, but not many places take my insurance. Nobody calls back. I feel like I'm treated differently. Most mental health providers do not accept Medicaid. So exacerbating some of that access to mental health, which is so important on physical health. And then frankly, it's expensive. They're on Medicaid based on income. And that can be incredibly hard to get the right care that they need and understand, not having to ration medication. This sort of graph on the right really highlighted some of the differences specific for our Medicaid members that we didn't see sort of across those other 7,000 members, looking at differences between Medicaid members without a chronic condition and those with a chronic condition. Those with chronic conditions felt like they didn't have as much support from their community. Again, highlighting sort of a disproportionate impact on being able to afford food. What I thought was particularly interesting is stress levels were high across the board. It's incredibly hard oftentimes for these Medicaid members that there wasn't a big difference between chronic and not chronic, that everybody seemed to be struggling, saying it was very difficult to deal with stress. So with that sort of level setting, I really wanted to, sort of hear from you first. And so we've got a poll question that'll pop up on your screen in a second. But I'd love to hear from the audience, what is your current approach to supporting your members living with chronic condition? Hopefully some of these findings resonate with you, hopefully things that you've seen. These are some of the questions that I often get from our Medicaid MCO partners. One, it's multiple choice, but rely on the primary care network. Do you deploy health education, health literacy materials? Do you rely on sort of a telephonic-based care management program, or are you deploying sort of targeted virtual care or remote patient monitoring programs? Maybe some combination of all the above. So I'll give a couple of seconds for people to respond to the poll question. And Eric, let me know if we're reaching critical mass on responses.
Yeah, absolutely. People are still voting, and we greatly appreciate that.
I feel like it is definitely an evolution across plans. We see a lot of, especially that sort of final answer where we play, rolled out to a lot of employers, large employers first, and then fully insured business, then Medicare. Increasingly seeing adoption in Medicaid can be a little bit more challenging. And so I'll be interested to see what these results. Okay. And so that's sort of what I expected, that there is a lot of you are using case management programs, understandably deploying sort of the health education, health literacy, relying on the primary care network. And then definitely a lot smaller, only about 22% were using virtual care remote patient monitoring programs. So that's perfect. And I'd love feedback sort of after our time together. We'll spend a little bit of time talking about our program. So here is Teladoc's program in terms of our approach to chronic care. We think that these three things have to work interchangeably to really drive the results that we achieve. And so the first thing is we've got to have data. If we're going to do any sort of virtual care program, or if we're going to do any sort of behavior change, we've got to get inputs coming in. So every member that joins one of our programs gets a cellular connected device or devices. So if they're struggling with diabetes and weight and hypertension and behavioral health, they'll have a connected scale, they'll have a cellular connected blood pressure cuff, they'll have a cellular connected glucometer, and they'll have access to our sort of My Strength or behavioral health programs. And all of that data is going to seamlessly go to us in the cloud. And then that's where the magic happens, where we're able to do what we call personalized health signals, where, if Glenn checks his blood glucose, we can instantly give him feedback saying, oh my gosh, Glenn, that's incredibly low. And that's where we'll bring in the human approach. We actually have telephonic outreach in under 3 minutes, 99.9% of the time. So if Glenn has a dangerously low reading, he's going to get a call from one of our trained diabetes specialists that can help him understand how to get in control, or God forbid, if he can't get under control, to call an ambulance, call 911, make sure that he gets to the emergency room and gets treatment. But that's where we think is really the magic of getting the data that we need from the member, personalizing health signals, driving that behavior change, and then combining it with the human element where, Glenn can talk to, his coach and get sort of unlimited coaching based on the feedback that the coach has at their fingertips. Hey, Glenn, I can see on the weekends your blood glucose levels are a little bit higher. Can you tell me about your diet on the weekends? What's going on from weekdays versus weekends, and really get to problem solving and work with the member, as opposed to, a lot of the traditional approach with chronic care. Hey, what's your blood glucose? Well, I wrote it on a napkin, or it's good. Good is not a clinical value. And so we find that data can be incredibly powerful. And then before I sort of hand it over to Rebecca to talk a little bit about engagement, I want to talk about some of our sort of high level results, and then we'll unpack these a little bit more, especially the clinical results with Dr. Davis. At the very front, we only think that programs work if they drive engagement. If people don't use the program, you're not going to get the clinical outcomes, and you're not going to get the medical cost savings. And so we think, again, that these are all critically important. You've got to design a program that works for people, that's helpful, that they love. We have a +60 net promoter score. If you're not familiar with how that's measured, it's, how often would you recommend to family and friends this program, and rating it a 9 out of 10 is critically important to get that high rating. So a +60 is close to a Netflix and Amazon and Apple, some of those consumer products that people love. And then 90% of members wanting to continue to engage with the program after year one, that they tried it, that they loved it, and that they're getting the clinical results. As you see, a 2.9% average A1C reduction for members that started in poor control, a 15 millimeter reduction in systolic blood pressure. A 10 millimeter reduction is equivalent to reducing 20% of cardiovascular risk, so heart attacks, strokes, incredibly important from a clinical perspective. And then, understandably, from a lot of our health plan partners, they want to know that the program works, that it saved money, that it delivers ROI. We see about $2,000 in different savings from members that are engaged in our program compared to those that are not engaged in our program. And it's not the sort of A students or selection bias. We make sure that we control based on risk. Oftentimes it's the members that know that they need help, the ones that are starting in poor control, that aren't managed, that know that they need some additional help. That human element, that tailored, personalized approach is really what drives those results. So I want to hand it over to Rebecca to really talk about how do we get members engaged in the program? How do we talk to Medicaid members differently? So without further ado, Rebecca, I'll hand it over to you.
Terrific, thank you. All right, so let's go to polling question number 2 before we dive in. This question is, what have you found to be the most effective ways to engage your Medicaid members living with chronic conditions? Our choices are direct mail, email, phone, text messages, or messaging in the health plan app. All right, we'll give this another sec or two. All right, let's close that out, and seeing strong results on phone as well as text. And I will say that if you struggle to make a choice on this question, that's probably for very good reason. When it comes to engaging members, there's really no one channel. We know that we need a multimodal approach, one that's really as diverse as our members to reach them, and is certainly as diverse as the Medicaid population. So let's go on to the next slide. I think that it's helpful to sort of start by thinking about what is the power of engagement. When it comes to engagement, sometimes the bottom line is at the top of the agenda. We know our clients want to do the right thing for their members and for their journey to better health. We also know that there's fundamentally a value proposition and a bottom line that they're accountable to. And when it comes to engagement, the good news is really that it's relatively simple math. If A equals B and B equals C, then we know that A, engagement, leads directly to C, lower healthcare costs. So if we go on to the next slide, we start thinking, how can engagement really meaningfully advance that journey to better health? And we operate under this premise. Engagement is it's fundamentally about driving adoption. We have to drive this forward by reaching members in highly personalized ways, in the places that they go and as they're making important healthcare decisions, and through campaigns that work within and complement clients' benefits and their communication strategies. And of course, powering this through a team of data scientists, engagement specialists is what's going to give this some true jet fuel. But as we move on to the next slide, I think that we also want to think about this as how can we make engagement truly a game changer? How can it shape an experience that empowers a member to progress on that journey to better health? And I mentioned data science. What begins with clinical and social data is really woven into an outreach and communication strategy that is going to be most likely to drive behavioral change. We have to do this through a trusted brand that consumers say can meet the broad spectrum of their healthcare needs, through partnerships that work within the systems that they already use, they already trust, thereby easing that access to care. Through journeys that are really as unique as our members, with hundreds of assets to apply across multiple stages of that journey. And through omni-channel capabilities. And I'm going to speak about this a little bit more because with each personalized notification, each care recommendation, every reminder, every eligibility reinforcement or an event-based trigger, this is how we're going to help increase the adoption curve. But we also know and we anticipate that behaviors evolve and they shift. And certainly this is very true with our Medicaid members. Information is consumed in micro moments, and we have to reach these members where they are throughout their spheres of influence. Our engagement really layers multiple channels to meet consumers across their decision-making process. So we know we are best positioned for success when they hear us on their podcasts or see us in TikTok, while streaming in Hulu, in their plans communications, throughout their Google search. And really building on this surround sound and layered with extensive data science, we then have levers that we can pull. Direct mail, email, text nudges, call center, our engagement center resources, all of those things that we were choosing in that poll to really create an omni-channel approach that can then drive higher response rates. We know that our Medicaid population is transient by nature, and to reach them where they are, channel diversification is really critical to creating a complete communication ecosystem. So let's look at a couple of examples here. If we dig a layer deeper on multi-channel engagement, we look at a case study of diabetes management for a large health plan. This client saw lower enrollment in the absence of a multi-channel engagement strategy. And after turning on a multi-channel approach, we see a significant boost, a 3x return on incremental members enrolled, and with it, a substantial healthcare cost savings each year. Similarly, when we take our direct mail communication for Medicare and Medicaid journeys and add to that outbound phone calls as a strategic channel, we're able to increase enrollment rates and to accelerate it. Really, at each opportunity for communication, we see that engagement is driving adoption. It has to be consistent and successive touch points that happen over consecutive weeks to really meaningfully drive that enrollment. And here we think about human behavior. Some members need to see more than one communication before they're ready. Success can really be cumulative as we're staying top of mind and we're really priming the member to feel ready to act. So just one more thought here. I know that when we talk about all of this, when we talk about these consistent touch points, a lot of folks might ask, are we risking overwhelming people? Are we overwhelming members with such a surround sound approach and these successive touch points? But truly, this is the proof that engagement yields results. In fact, we see that the more that members have access to, the more we reach them where they are in their healthcare journey, the more positive the response. We see an 8-point higher NPS for members using multiple telehealth services, 2-point higher NPS for members with access to multiple chronic care management services. And this one I find really exciting. We see a 20% additional reduction in A1C levels for each additional chronic care management program that a member is enrolled in. So with that, I'm going to hand it off to Dr. Davis to keep us moving along.
All right, thank you. Let's take a look at polling question number 3. What is the best approach to achieve clinical results in addressing members living with chronic conditions? Here are your options. Number 1, address both physical and mental health. Number 2, address all chronic conditions and don't address in isolation. Number 3, address conditions in simple, easy to understand manner. Number 4, address conditions in a sustainable way. And number 5, address in a way that is culturally competent and factors in social determinants of health. I'll give you a few moments here. All righty. Let's take a look here. So what we see as being most important is addressing in a way that is culturally competent and factors in those social determinants of health. Others that are close behind, addressing conditions in a simple, easy to understand manner. And of course, in a sustainable way that doesn't involve, I would say, a rigorous diet or anything along those lines. So really nice answers, and really you could almost say all of the above. Really great answers here to these questions. Let's go ahead and move forward. So we at Teladoc do understand that diabetes and hypertension don't occur in silos. People say sometimes, diabetes keeps bad company. And certainly those members who have diabetes are likely to have weight issues, hypertension, mental health concerns, and the same for those who have hypertension. So our theory is that an integrated approach, an approach that really leverages multiple solutions in one program, is going to give us better results. And we certainly see that. Looking to the left here on the slide, those members who are enrolled in diabetes +1, +2, +3 other solutions are getting amplified results, incrementally improved results of 0.2 percentage points with each additional solution being added. And if you look to the right, you see the same thing with hypertension. Again, it doesn't exist on its own. Certainly you have other medical conditions that exist along with that in most cases. And you see adding that weight management or diabetes piece, or certainly that mental health piece, can really improve our results in increments of 5 millimeters of mercury or increments of 5 points, improved reduction across the board for systolic blood pressure. So really important, the integrated approach is something that does work. And we proved this out with a study of over 25,000 of our members over a course of a couple of years. So great results here, and that really does inform our approach. We also learned that mental health is a key driver of results. You think about adding a mental health solution to a comprehensive integrated program, and what you see is, for example, for diabetes, a 0.5 point reduction in A1C, additional reduction in A1C for those members who are starting out with an A1C greater than 7. Similarly, when you think about hypertension, for those members starting with stage 2 hypertension, we see an additional 10 millimeters or almost 10 millimeters of mercury, 10-point reduction in systolic blood pressure. And for reduction in weight, for those members who are obese, we see an additional 1.8 percentage point reduction in body weight for those members who are using that mental health solution along with our weight management program. And that's over the course of 12 months. But what we see over the course of the first 60 days for those members who are using the mental health solution in conjunction with chronic care programs is a 5-point improvement in the WHO-5 score. It's a score that's used to measure a member well-being. And the WHO-5 score increase of 5 points does indicate that working on mental health as well as improving chronic care conditions has a very rapid effect on improving overall well-being for the members. Just to drive that home, we'll double click here on diabetes. Looking at diabetes itself, for those members who start out uncontrolled, that A1C greater than 7, we see a 50% reduction, incremental reduction of 50% more, that extra 0.5 percentage point reduction for those members starting out uncontrolled. And for those who are most poorly controlled, that A1C greater than 9, what we're seeing is an additional 0.7 point reduction in A1C. So a really fantastic result, just driving home that notion of mind-body connection being part of that, a key part of the whole person approach. And looking at the mental health component again, we see 54% of these members dually enroll in the diabetes program plus mental health, enjoying a 10% increase in their WHO-5 score. So just double clicking here on diabetes and driving home that same point. And then of course, we think about our solutions can deliver outcomes quickly, but they're also sustainable. This, for example, is diabetes. What we see here for members who start out with that A1C greater than 9, a 2.9 point reduction in the course of about 3 months, but then the result is sustainable over time. We talked about doing something that is sustainable over time. You need to pull on more than one lever. Certainly, we want to make sure that members are watching their diet and concerned about what they're eating and being coached there, either digitally or one-on-one with expert human coaching. We want to make sure that members are getting more exercise. We can track that on Fitbits and other digital solutions or even on their iPhone. And then also we want to make sure that members are more adherent to their medication. So we really do drive that home. And what we found, again, looking across one of our studies we did with a PBM that we're affiliated with, they saw that members are almost twice as likely to be adherent to their medications if they're involved in our program for 1 year period versus those members who are not in our program. So really great results there. And finally, getting members in the right headspace, really working to make sure that they are mentally ready, whether it be with working with our health coach and trying to figure out how to tackle certain barriers, such as the cost of medications or making sure they can prepare the foods that they need to prepare. Or it could be actually using a mental health program. As we mentioned, members who have diabetes certainly are more likely to have those mental health concerns. Can we have a mental health program to really get them in that mindset to go ahead and be successful here? So that's really a holistic approach. I know there are those out there who believe that there's a rigorous diet that can change your life. And there's a exercise program. If you just do this boot camp and this will really solve your issue. Of course, you think about the sustainability of that program, that type of program, even if you can get someone to succeed, unlikely they'll be sustainable long-term. So we want a holistic program that is something that members can really embrace over the long term. And we know in medicine that there are structural disparities in our society that really drive, unfortunately, different states of health within different racial groups. Social determinants of health, if you look very closely at the categories, we know that race is a factor in income and neighborhood that you live in. being in a food desert, having lack of access to primary care, and other issues that we see with whether we think about with social determinants of health. So looking at that, what we see here is for, again, looking at our book of business, for those members who are non-Hispanic white, you see that they start out members who with a proportion of members with an A1C greater than 9% of 12.7% proportion of that population. For African Americans, 16.9% of that population has an A1C, starting A1C greater than 9. And for our Hispanic population, we see 19% starting out poorly controlled, that A1C greater than 9. But our program is able to deliver outcomes that really help to level the playing field and drive equitable results. And what we see over the course of 6 months or longer is those members who are African American have a proportion of members with that A1C greater than 9 that drops to something that's very comparable to the non-Hispanic white population. And Latino population also enjoying a fantastic result, maybe not quite aligned with the non-Hispanic white population, but a significant drop, a greater percentage drop of 51% as compared to 39% for their white colleagues. So really great results. And again, our goal is to build programs that deliver equitable outcomes and sort of level the playing field. We know that's been an issue in healthcare for years, and we want to break that cycle and really deliver outcomes that can be effective across different racial groups. And we've even seen with our African American population, those members starting with an A1C greater than 10%, we see after 6 months, that proportion of members drops down to about 3%. So fantastic result, even for those who are most poorly controlled. Okay. So what can we do to make healthcare even more accessible, even break down more barriers for our members? Well, one thing we can do is in-meter messaging. Again, our Livongo meter, as was alluded to earlier by Hunter, is a meter that not only allows us to collect information seamlessly through a cellular connection to the cloud, but we can also push nudges, digital coaching nudges through that meter and help members better understand how to take care of their condition. Another thing that we can do is make sure that members are doing those routine steps in diabetes care that are so important to really make sure that they are maintaining their health, such as making sure they're getting a regular eye exam. And we can certainly push a message, hey, have you gotten your eye exam this year? If you'd like more information, just press yes. And we can help the members locate an eye doctor that is in their network locally and help them really link up with that eye doctor to make sure they get that eye exam on a regular basis. Same thing can be done for diabetes foot exams, or even for A1C testing. And we can say, hey, have you gotten your A1C testing done the past 6 months? If no, then we'll send you information about how to get that A1C test done. So really closing those gaps in care using our meter to help us communicate with members. And I know that was an issue that was brought up earlier in one of the questions, how to communicate with members. This is one channel that can be utilized. And of course, now we have at-home A1C testing, which is really convenient. And we've used this with over 100,000 members. We can, again, send a prompt. Do you know your A1C? If you'd like to have your A1C tested at home, get a test kit at home, simply press here, yes, ship it now. The member receives that A1C test kit in about 2 to 3 days. They can go ahead and collect their blood and send it back in, that kit back in through the mail to the lab and get that test result in about 3 to 4 days. Nice turnaround time. What we've seen is a really nice opt-in rate, about 58% of members opting into this program. And the return rate, typically across the industry, you see about a 5 to 10% return rate for at-home test kits. What we're seeing is about a 45% return rate, with about 87% of those members who do return the test kit having an A1C of less than 8. So really great way to, again, take barriers, remove barriers for members who may otherwise not get the test done, make it really easy. And then thinking about quality measures and being able to submit quality metrics for HEDIS submission. This makes it really easy. You see 87% of members here with that A1C of less than 8%. Fantastic result, and certainly looks good for HEDIS submission.
Well, perfect. Dr. Davis, I think you do a fantastic job as always, just really highlighting some of those clinical results. I've seen a couple of questions come in. Would love to hear any other Q&A that sort of come in while we do it. I might tee up a couple of those for you all. Before we do, I just wanted to hit maybe summation of what we've covered so far, and then want to have the remaining time as sort of an opportunity for you all on the line to sort of ask questions, engage with us. But I would just say my key takeaways, what I hope you sort of picked up from our time together, is just members are overwhelmed and struggling to manage chronic conditions. We think a new approach is needed. Obviously, we're biased to what that approach might look like. But we would just challenge you as Medicaid MCO leaders, thinking through going beyond the telephonic outreach. How do you engage more members than you're touching today and really help them make the healthcare system easier, especially for those living with chronic conditions? We again think that the multimodal approach is required. That was sort of the trick question. It's not one channel, it's all the channels. And that's one of the things we constantly are working with our Medicaid partners. It's difficult to drive engagement. There was a question about what's your Medicaid engagement. A lot of that's driven by what are the options. If we can use text, if we can use phone, if we can use email, that opens up a lot of opportunities. Sometimes Medicaid plans are more reluctant to leverage some of those other channels, and it can be heavier reliant on direct mail. And then the ability to offer tailored and easily digestible guidance. I think there was a question in the chat about, do you personalize? Absolutely. Everything we know about the member is used to engage with the member. I'm pre-hypertensive and I'm using our hypertension program. I had reached out to my coach, and said, oh my gosh, my readings are a little bit higher. And they said, Hunter, I noticed that you're checking usually between like 11 and 3. That's probably in the middle of your workday. Why don't you try checking in the morning, before you've had your coffee, while you're sort of at rest? Magically, my blood pressure went down. And so able to really contextualize all the things and really personalize that for the individual. That's sort of a silly example, but we do that at scale, especially for our members living with multiple chronic conditions. And then, as Glenn mentioned, certainly mental health, but just the multi-condition approach in general. Rarely are people living with just diabetes, just hypertension, just with weight. It's not like they have the opportunity to say, on Wednesday, I'm going to manage my diabetes. On Thursday, I'll manage my hypertension. It really does need to be an all of the above, really full contextual approach to members. And that's why we are so focused and passionate about taking that multi sort of condition approach with our members. And working with our Medicaid partners in particular to think about how do we expand that, provide more benefit to more members. So with that in mind, Eric, I know there's a couple questions that you've received. I wanted to answer a couple that have come in. Glenn, I would love to hear from your clinician's perspective. There was a question about sort of segmentation. If a member has an A1C greater than 9.5, do we, not let them join the program? What if they have cancer? I think I'll answer just briefly that we work with our partners, and the beauty of our model is it's per participant per month. So you only pay based on members that enroll in the program. And because of that, can be incredibly flexible. Let's start with a high risk population. Let's look at everybody with an A1C greater than 8 or haven't had an A1C in the past 12 months and, comorbidities of CKD and hypertension. Absolutely can work with partners to really tailor who we want to include in the program. But what would you say, Dr. Davis, from a clinical perspective?
Yes, I would say again that our program is not a one-size-fits-all program. Certainly, we have the ability, when you think about the different levers we pull with exercise and diet, medication adherence, getting people in the right mindset to be successful, and that health coach support, that one-on-one support that someone may need if they're living with other conditions that we're unaware of. Let's say they also have a seizure disorder as well, along with diabetes. We can help make sure that we're using diet, make sure that we're doing things that will not interact adversely with other conditions, and really personalize it for the members. So I would say that our program is not one size fits all, but in a way, it's a sort of a choose your own adventure. Which route would you like to take to that path to better health? We're able to help members regardless of whether they start out with a more acute, a higher A1C, or an A1C that's a bit better control. Help them even drive better control and be more confident managing their condition, regardless of where they're starting out.
Yeah, I think that's great. And then Rebecca, next question for you. There's some limits in what we can disclose as a publicly traded company in terms of, specific enrollment rates. And, as you all on the phone know, if you've seen one Medicaid program, you've seen one Medicaid program. But Rebecca, what can you say in terms of just enrollment rate trends that we see across different partners and sort of how that varies based on sort of the channels that we have available to us?
Yeah, absolutely. And I think that you touched on this briefly, Hunter, that, truly it depends. It depends on how many channels we can use to be able to engage that member. When we layer on phone, when we layer on text, when we layer on direct mail, when we layer on email, the more channels that we have at our disposal to be able to engage a member, the more likely we are to catch them at that moment in their journey. I mentioned earlier that this is often successive and it has to be layered on top. It might take an individual member 4 times, 5 times to hear that message and to see it and in different parts of their ecosystem before they feel like they're really ready to act on it. Some members might just need one touch point, but another, it might just be a little bit more further along in that communication pipeline. The answer is truly, it depends. And the more channels that we have at our disposal, the stronger our engagement will become and the stronger the enrollment will become as well.
That's perfect. Hopefully that answered the question. So Eric, I know there's been a couple other questions that have been coming in sort of on the private line. What else have you seen, Eric?
Yeah, absolutely. So thank you to everyone who has already submitted questions. Like Hunter said, if you have questions, please submit them using the Q&A button at the bottom of the screen. This first question I will toss to Dr. Davis. Dr. Davis, how are you engaging and creating awareness of mental health offerings within the Medicaid population? And what about the pediatric and adolescent mental health?
Well, certainly with our Chronic Care Management Plus and Chronic Care Management Complete programs, which really do include our entire suite of chronic care solutions, along with our mental health solution, that's already really baked into the product, which again, you think about, we had a meeting with a CMS executive a few months ago, and she mentioned that for members who start out with an A1C greater than 9, 2/3 of them are dealing with a mental health condition as well. So it almost doesn't make sense to try and attack the diabetes side of the issue without attacking also the mental health issues that the member is living with. So that's baked in. And we think about the adolescent group. Certainly for our digital program, our My Strength program, we do have the ability to accommodate members down to 13 years of age. And always looking at new opportunities to have additional offerings for adolescent and pediatric patients. So I don't think that story is completely written yet, but we do offer that digital solution for members down to 13 years of age.
Great, thank you so much. This next question, I think will go to Hunter. Hunter, how are you effectively closing gaps in care to raise HEDIS measures?
My favorite acronym, especially this time of year, is everybody's struggling to deal with results from last year. The great news is NCQA continues to evolve sort of different data collection methods. So we were thrilled in terms of, we've always offered this hypertension program for years. Suddenly in 2020, we could use that data to improve numerator compliance. And so we had one partner that used data from our blood pressure cuff to improve their HEDIS performance by 9 percentage points. So almost the difference between going from a 25th percentile performance to a 70th percentile performance. And so having a lot of partners really reach out to us, given how heavily weighted that measure is in a lot of state withhold programs. Dr. Davis mentioned the A1C. We've always had blood glucose data. We estimate an A1C. Unfortunately, you can't use an estimated A1C for HEDIS reporting, but that's why we've started doing home lab testing. And that's why those really high opt-in rates, really high return rates are so important, because we can take the great clinical results we're seeing and translate them into HEDIS performance for our partners. It's a different line of business, but it's publicly available. The Medicare Advantage results came out 2 weeks ago for our partners that we were working with in 2021. All of our partners were at a 5-star level of performance for A1C control and blood pressure control. We can't take credit for all of that since we don't have 100% of their members, but we'd like to take credit for some of that. And so spend a lot of time on med adherence, on sort of some of the related process measures of eye exams, of kidney function testing. And so continuing to do a lot of investing with our product team to think through how do we drive nudges, how do we change behavior, and then how do we do what we call last mile gap closure with some of the home testing options.
Great, thank you. The next question is, Dr. Davis, during your portion, you mentioned different outcomes for race. What programs are you using to get in touch with members, and how are you saving on costs for these members?
As we mentioned before, we do have the ability to use multiple channels to be able to communicate with these members. And I think that, the app itself, the glucometer, or the ability to communicate with members using those channels, really valuable. Again, it can be difficult for any of us. I don't know how many of you open up your mail. It tends to go for me straight to the shredder. But I think to really get a hold of members, you need to find them where they're living at the moment. And the ability to have it messages coming through the glucometer as someone has just finished completing the blood glucose check. You have them engaged right there. It's a great opportunity to engage a member regarding whether it be diet recommendations, different checking pattern recommendations, or hey, go get your diabetes foot exam recommendation. All those recommendations are right at their fingertips while they're engaged. And again, that app, I can't think of a moment when I don't have my phone within 5 feet of me. And as soon as they click on the app, another opportunity to engage the member on a host of different issues with various conditions. That digital coaching that we provide is hyper personalized, so that the messages that I may get as someone who has hypertension and maybe borderline prediabetes would be different than someone who has an A1C of 10 and has stage 2 hypertension. So hyper personalized in a way that is similar, I consider it, to an Apple playlist, where mine may be different than Eric's. So those are some of the channels that we use to engage members, no matter who they are, where they live. We have those channels available.
Yeah, and Dr. Davis, just to pile on, I think you raised a great point of a lot of times people aren't trying to think about their healthcare. That's the last thing they want to do. They want to live their life. But by definition, when you're checking your blood glucose or your weight or your blood pressure, you are thinking about your health. And so that always blows a lot of our plan partners' minds that members engage with us almost on average, almost every day. And think about how often they want to engage with their health plan, not that often. And so we do have that unique trusted opportunity where we're building that trust, we're personalizing feedback for them. And then we have that opportunity to talk about that next best action of, hey, it might be time to get your eye exam. It might be time to have your A1C checked. Really creates an opportunity of engagement driving behavior change.
Great, thank you. Our next question talks about digital health solutions. So how can a digital health solution facilitate care delivery for physicians in the primary care brick and mortar space? Dr. Davis, I think this one, do you want to start with this one?
Absolutely. So for most primary care physicians, they get maybe 20 minutes per year, maybe twice per year with one of your members. And during the other 364 days out of the year, they are dealing with all the pressures of life, all the stresses of life, all the poor dietary options that are available, or maybe having difficulty if they live in a food desert, accessing the right types of food that they would like to access. And so by having a program, a digital health solution, we can engage that member on a daily basis with regards to just those issues. How can we help you manage that stress? How can we help you make the proper food choices? How can we, working with a health coach, what are the right foods that you should be eating? How can you access them? How can you access SNAP or WIC? How can these programs be accessed easily in your area? And so we are able to do that in a way that the primary care physician who sees someone once or twice a year and has 10, 20 minutes with them, they're not able to provide that same type of guidance. So I think that's really where we offer value. And I think primary care physicians appreciate it as well. I mean, everyone in primary care knows that we are stressed and don't have enough time to spend with our members and patients. And so this is another way to augment the capacity of primary care physicians that are in your network.
Hey, and Dr. Davis, I'd love to maybe say a little bit more about the health summary report. Sort of an anecdote I share a lot is when we first started our chronic care business about a decade ago, we were like, oh, every doctor is going to want every single blood glucose reading, every blood pressure reading. And they're like, please don't do that. Please don't send me your Fitbit data. Like, I'm just looking for the big picture. Say a little bit more about that, Dr. Davis.
Sure. So the members have the option of sharing a health summary report. It's available on their glucometer to share it out via text, email, or fax, and also available through the app. And it is the first 2 pages are a summary of what their blood glucose readings have been, what their blood pressure's been, what have been the ranges, when have they had emergency contact with a coach due to a high or low blood sugar, all that information really being synthesized in a 2-page summary, which for a primary care physician who has 15, 20 minutes to spend with a patient, easy to take a look at and glance and say, okay, within 90 seconds, they can get a snapshot of what's been going on with the member. So very valuable, the health summary report, and something that's easy to share out by the member.
Very cool. Great. Okay, so the last question we have received so far is members are inundated with targeted marketing every day. I think everybody is, how do you know when engagement becomes too much or not enough? Rebecca, do you want to handle this one?
Sure. This is where I think data science plays a huge role. We are consistently learning, testing and learning in terms of where we are getting the best engagement. We have created an optimal enrollment plan that really speaks to this, to say, what is the volume of communications? What is the cadence? What is the what is the thematic content that we need to be able to engage a member without overwhelming them. And in fact, we are able to reach sort of that sweet spot of what is just the right amount without overwhelming. I mentioned some of those health metrics, the NPS scores, that show us that successive engagement is actually giving us better results. It is telling us that indeed we are not overwhelming, but rather we are reaching members at just the right amount. Less has diminishing returns, more might have diminishing returns, but getting just that right volume within an optimal plan, and layering in the channels to, again, reach them within the moment that they're in their journey, wherever, particularly for a Medicaid member, they might be within, receiving their communications within their ecosystem, is really the critical point. So it's about data science. It's about watching these things very closely, learning all the time, and always being willing to evolve our plan as population behaviors shift, evolve, change as people do.
I think that is great. Well, we have a couple minutes left, but we very intentionally at Teladoc try and wrap things up a little bit early so that you can focus on your next meeting, as I know everybody's got a lot of back-to-back. But Eric and MHPA, just want to thank you for the partnership. I want to thank all of the attendees for joining, and I want to make sure that you know that we're available. That we'll send the slides out afterwards, and I'll include my email and contact information. I'm happy to work with you, or if you've got other contacts at Teladoc, just would love the privilege to talk to you more about how can we serve your Medicaid members, and would love to be partners with you. And I hope you all have a wonderful rest of the day and rest of the week. Thanks.
Great. Thank you to Glenn, Hunter, and Rebecca for their very insightful presentation. Just a reminder, as Hunter just said, they will be sending the presentation slides out with their follow-up communication. You can also find a recording of the webinar on MHPA's YouTube channel if you want to go back and visit it in the future. So thank you again for your expertise on this very important issue. We really appreciate you guys addressing our members and our audience. And finally, thank you to all of our attendees. We really appreciate you guys spending time with us this afternoon. We hope that you found the webinar today to be valuable, and we hope that you join us again in the future. Thanks again, everybody, and have a great afternoon.
Thanks.